So this section, we're going to focus on some of the practical issues and factors that weigh into our decision on what therapy to start first with for patients with metastatic renal cell carcinoma. And we're going to start first with risk stratification for metastatic renal cell carcinoma. Bob, do you want to walk us through a little bit of the models that we use and how you use them in practice?
Certainly. The two main models that we're presently using predominantly is an international RCC model, the select patients, and the Memorial Sloan Kettering model. And again, these have adapted over the course of years from focused more on cytokine therapy to now targeted therapy. And I suspect immunotherapy may make a slight difference or a tweak. But the bottom line is performance status. If your performance status 0, your prognosis is going to be better than if your performance status 1, 2, and then of course 3 or 4. So selection for clinical trials, performance status is always going to be a key criteria. A criteria that has not gone away but has been discussed earlier, nephrectomy versus no nephrectomy, and the influence of the kidney intact versus the kidney out. How long has the kidney been out? The history behind it relative to the metastatic presentation. Was it a year, 6 months? Was it 10 years? And that's going to vary in outcome as well. I don't think it should change the selection of agents unless one has a particular interest in a combination or single agent based on the data that's in front of us and be presented at ASCO 2018. Well, whether you choose a TK or a single agent VEGF antibody versus combination checkpoint inhibitors or single agent checkpoint inhibitors. So risk stratification, what other comorbidities exist? We know these drugs have cardiovascular issues that we have to pay attention to, work closely with our cardiovascular team. And especially, as Walt mentioned, when these patients go to the ER, they may not be going to the ER for their cancer. They're going as a result of an arrhythmia or shortness of breath that has congestive heart failure. And then changes get made inappropriately without discussion with the treating and planning oncologist. And absolutely agree with them, and it's correct. And each of these drugs have their own particular side effects that we have to be careful for. And they're manageable, and to some degree can be reversible, but to some degree they're not reversible. So how we choose agents based on whom's in front of us. You have a good prognostic patient, and they have various comorbidities that don't allow us to select a sunitinib or a pazotinib. And the challenge with sunitinib is which schedule is the best schedule to use now? Is it this 2-week one? Is it this every other day? Is it the FDA approval schedule 4-2?
You bring up some great points, Bob, and I'm going to stop you there because I think we want to get to a lot of these things, and you've raised a lot of really important questions.